GI anatomy, femoral triangle, and inguinal canal. All right, so the femoral triangle is going to contain the femoral nerve, artery, and vein. The way that you remember this is naval, okay? So from lateral to medial, you have the femoral nerve, femoral artery, femoral vein, and then the closest one is going to be the lymphatics. Okay, so people remember it via naval, or they can also remember that the venous is near the penis for you to remember the order, all right? But that's pretty much the femoral region altogether. Next is the inguinal canal. The inguinal canal is very high yield for hernias, specifically the inferior epigastric vessels. But before we talk about the inferior epigastric vessels in association with hernias, we have to talk about them being at risk for injury. So any patient that's undergoing a rectus abdominis surgery, like a surgery that's involving the rectus abdominis muscles, these are at risk for injury, okay? So what you need to take away from all of this is hernias, because this is the high yield association with the inguinal canal. But before we talk about that, we must discuss the first hernia is the diaphragmatic hernia, okay, which does not involve the inguinal canal, obviously. This is near the diaphragm. So what happens here for the diaphragmatic hernias is your esophagus and the portion of, kind of the top portion of your stomach herniates through the diaphragm, okay? And what you need to know is that there's two separate types of diaphragmatic hernias. You have the sliding hiatal hernia and the paraesophageal hiatal hernia. The sliding hiatal hernia is where pretty much the whole entire fundus slides upward through the diaphragm, okay? And you can take a look at that, what it looks like from a standpoint of comparing it to a paraesophageal hiatal hernia. But what happens here is really important because it's usually due to laxicity of the phrenoesophageal membrane. So what they're trying to tell you is that you have laxicity of the diaphragm where the esophagus meets it, and it leads to kind of just the tugging out and herniation of the fundus of the stomach, all right? It's pretty much just the upward displacement of that, all right, of the gastric hernia. Now, this is highly associated with GERD. On the other hand, we have paraesophageal hiatal hernia. Okay, take a look at what that looks like. And this is where you pretty much have the gastric fundus protruding into the thorax. Okay, so the cardia is still going to be downward and not in the diaphragm, not above the diaphragm, but the fundus is actually protruding in. So it's paraesophageal hiatal hernia. All right. Now, what you have to know with this one is that it's associated with the volvulus, increased risk of volvulus. All right. So sliding hiatal hernia has association with GERD. Paraesophageal hiatal hernia has an increased risk for volvulus. All right. And the sliding hiatal hernia is usually due to laxicity of the phrenoesophageal membrane. All right. So that's pretty much what you need to know about the diaphragmatic hernia. In infants, for diaphragmatic hernias, it usually is a congenital defect of the pleuroperitoneal membrane, and it's going to be mainly left-sided. The reason behind that is because the right side, the right hemidiaphragm, is going to be protected by the liver, okay? And once again, if you see like the NG tube within like the lung region, you see like bowel loops on x-ray of like an infant, then you know that it's a diaphragmatic hernia that involves congenital defect of the pleuroperitoneal membrane. But remember, in adults, it's usually due to laxicity of the phrenoesophageal membrane. All right, finally, we're on to the inguinal hernias, okay? So we have two types. We have indirect inguinal hernia and direct inguinal hernia. This is high yield. For indirect inguinal hernia, it's going to go through the internal inguinal ring and the external inguinal ring, okay? And so it's going to end up into the groin via that mechanism. What you have to know that's very high yield is that indirect inguinal hernias are lateral to the inferior epigastric vessels, okay? Another high yield association with indirect inguinal hernias is that it's caused by a failure of the processus vaginalis to close, all right? So it can be associated with hydrocele because hydrocele can be caused by a failure of the processus vaginalis to close, all right? So indirect hernias, along with hydroceles, are associated with one another, okay? Now, this can be noticed in infants, or it can be noticed in adulthood, all right? It's more common in males, and it's going to be covered by all three layers of the spermatic fascia. But what I want you to take away from indirect inguinal hernias is this. 1, it's going to be lateral to the inferior epigastric vessels. 2, it's due to the failure of the processus vaginalis to close. And because of that, 3, it's associated with hydrocele. Next is direct inguinal hernia. Direct inguinal hernia got its name because it directly protrudes through the inguinal triangle, okay, through the parietal peritoneum, right? So it goes directly through the parietal peritoneum. That's why it's called direct inguinal hernia, all right? And it's going to be medial to the inferior epigastric vessels, all right? Now, the reason that it can directly bulge through the parietal peritoneum is due to the fact that you're going to see it in older males. Okay, so this is a high yield association in older males because they have a weaker abdominal wall. So that hernia can occur directly through the parietal peritoneum because they're older and they're weaker. All right. It's due to transversalis fascia weakness. That's why it's highly seen in elderly, specifically older males. All right? So the key takeaway for direct inguinal hernias that I want you to know is one, it directly bulges through the parietal peritoneum because of an acquired weakness of the transversalis fascia. Hence, it's most likely seen in older males. And lastly, it's going to be medial to the inferior epigastric vessels. Okay, that's our direct inguinal hernia. Lastly is the femoral hernia. The femoral hernia is going to protrude below the inguinal ligament. Below the inguinal ligament is very important because we discussed previously that the femoral region or the femoral kind of triangle, the superior portion is going to be made up of that inguinal ligament. So if it protrudes below the inguinal ligament, it will be in the femoral triangle. Okay. Now, it usually is going to be most common in females, but it's increased risk of incarceration or strangulation. Okay. Incarceration meaning that you're unable to push it back up and resolve the hernia. And strangulation means that when it becomes incarcerated, it starts to lose blood supply. Okay. So if you see a female with a hernia below the inguinal ligament, if you ever see a hernia below the inguinal ligament, it's going to be a femoral hernia. Okay. Increased risk of strangulation and incarceration compared to inguinal hernias. All right. Now, last thing I want you to know about femoral hernias is that it's most likely going to be medial to the femoral vein. Okay. And that's all for our hernia chapter and anatomy overall. If you have any questions about GI anatomy, please reach out. I think it's very key to understanding all the pathologies we're going to discuss later on.